It's not the intervention, it's not the medication, it's the human connection, which oftentimes is the source of suffering, but then also the source of healing, hope, and inspiration.
Hello, everyone. This is Cole from the American Journal of Healthcare Strategy, joined by a very important leader today with, many years of experience, a really tremendous amount of experience, and it's in an area that we're really facing a crisis with continuously as a country. Dr. Urzan, please introduce yourself and your current role.
Great. Thank you for having me on, Cole. My name is Dr. Damir Utrzan, and I'm currently the Chief Compliance and Strategic Development Officer at Horowitz Health. I have been with the organization for a little under 2 years, but prior to that, I worked as a mental health manager at the Hazel and Betty Ford Foundation in Center City, Minnesota. And before that, in the direct care and treatment administration within the Minnesota Department of Human Services.
You started back at Rockford, according to LinkedIn, with a bachelor's in psychology, human development and philosophy. Then you got your master's at Northwestern in marriage and family counseling. You got your doctorate, your PhD at the University of Minnesota. You did a postdoctoral fellowship. And then, of course, you've been in the field many, many years working with so many different organizations. So you really are an expert in this space. I have to ask, what has led you to Horowitz Health, especially in the role that you're in as chief kind of compliance and strategic development officer? That is a more business focused role than what you've done in terms of as a clinician. So how does that change, and what drew you to doing that?
Absolutely. That's a great question, and it highlights some of the underlying factors or considerations around the topic that we're discussing today. So, when you're in a terminal master's degree or even a doctorate, you're not trained or taught around operations or business, right? Unless you maybe take an elective, you're trained to be a clinician first and foremost, at least in the master's level. At the doctoral level, you're trained as a research scientist in order to look and take apart logical arguments so you can design strong methodologies to execute research studies. And so, to some degree, they are opposite sides of the same spectrum, right? Whereas business leadership draws on different parts of the continuum. And so often we'll see clinicians who are great at delivering psychotherapy or medicine, if that's what their field is, but not so good at transferring those skills to business operations and leadership, despite an underlying factor being interpersonal relationships. And so when I finished my postdoctoral fellowship at the University of Minnesota, I was looking for initially teaching opportunities, right? I was trained to be a clinical scholar, and so I interviewed all across the country at medical schools, at research universities, but it didn't really align with my values. At the time, I couldn't really put words to it, but it just didn't feel right. And then an opportunity arose with the Minnesota Department of Human Services as a treatment director of an intensive residential treatment services facility. So in Minnesota, those facilities are licensed under the Uniform Standards Mental Health Act, or Uniform Service Standards Act, USS 245I, and they provide a level of care that is just below the hospital inpatient. And it's designed to treat up to 16 clients for a range of 30 to 90 days by stabilizing their functioning, returning them to a baseline, whatever that may be for them, that's individualized and person-centered, and then discharging them back into the community to prevent the revolving door of re-hospitalizations. And I really enjoyed the ability and freedom to combine clinical practice, scholarship, and leadership. So that was really unique. And especially being governmental, I got to see the policies, procedures, and various aspects that go into operating a facility. That program subsequently closed down, and I went to the Hazel and Betty Ford Foundation, where I oversaw the also licensed under 245I, an outpatient mental health clinic with psychiatrists, about 25 staff overall, serving, a campus of slightly over 300
Mhm.
clients.
Wow.
And that's where I still maintain the clinical practice because under this law, you have to be licensed as a mental health professional to be in said leadership position. But I also worked with senior leadership to evaluate, for example, psychiatric acuity protocols
Mhm.
and implement measures for curbing referrals so we can triage the most acute clients or patients, if you will, and thereby marshal resources accordingly, right? What you may experience as anxiety may not be the same as another person or as I would
Mhm.
experience it. And after that, I got an opportunity to work with Horowitz Health. And what drew me here was, another evolution in my career, if you will, where Drew Horowitz, president and chief executive officer, was well known in providing outpatient substance use disorder treatment and medically monitored detox or withdrawal management. But because substance use disorders are mental health disorders and the dichotomy and separation is arbitrary to some degree, he also wanted to expand into the mental health continuum. So, over the past almost 2 years, like I said, I've worked with a team here to license 3 intensive residential treatment services facility, one outpatient mental health clinic, and 6 outpatient substance use disorder treatment facilities.
Wow, so you've grown drastically then in terms of the amount of individuals that you're managing and the complexity of the situation. I want to ask the first place you mentioned that the program had shut down, and that's one of the things that we're seeing across the country is consolidation, but we're also seeing a lot of challenges. And one of the things I brought to you when we had first spoke was that everyone I'm talking with is saying that it's a policy problem. And you said that that might be true in different states, it might be true in different circumstances. But from your perspective, yes, the policy could be improved in some ways, but there's this other aspect of things that maybe people aren't seeing in terms of efficiency, management, and then even
Mhm.
greed in some ways, where people,
Mhm.
especially in VC, need to kind of extract as much kind of resources as they can to keep moving their portfolio forward. I want to
Mhm.
ask, when it comes to staffing specifically, because now you're overseeing a large amount of staff. Everyone is complaining about staff shortages. Are staff shortages due to education? Is it due to the compensation, the work environment? Why do you think everyone is complaining about staff shortages in behavioral and mental health?
The answer is all of the above to
Mm,
some degree, right? And I don't know if you've ever heard of the term equifinality.
I've not.
That equifinality just means that there's multiple ways of getting to the same endpoint,
Ah, yeah.
right? And the reason I bring that up is because certainly since the pandemic, there has been a shortage of mental health professionals, independently licensed providers, psychiatrists, because of the burnout, the exhaustion, the long hours. And the human body is unique in that we can adapt and survive for a relatively long period of time in highly stressful situations. But once our cortisol levels decrease and return to baseline, there's a sense of exhaustion, and that's both physical and psychological. The other part that you have, and we're seeing that as a compounding effect of the rapid growth, expansion, and mergers, which, over the last year, we've seen significantly more mergers than we have in the past 4 years combined. And so if you look at even the facility that I'm in right now that we're opening, it's licensed for 16 beds, has about 22 staff, and I think 4 mental health professionals. So
Mm,
it's a very high staff to client ratio given the intensity, and it's 4 mental health professionals. But putting that into context, on average, doctoral degrees are, states with universities that have clinical doctoral programs award maybe 16 doctorates a year,
wow.
right? So cohorts are between 3 to 6 individuals, and then it takes 2+ years for fellowship, specialization, and licensing. So it's a very prolonged and protracted process to some extent, and the need, whether that be business or clinical, simply is outpacing the availability because you can't train clinicians that quickly. And so what we've seen in response is, more hybrid or virtual uh, opportunities. But even then, it's been subsequently um, faced with barriers and legislation and policy, in that you need to have waivers and different approvals to offer telehealth services following expiration of the pandemic emergency exemptions.
But telehealth doesn't work for all these situations. It doesn't work for the people that you are seeing.
At times it may, like for psychiatry, for example, we're fortunate enough to have a lot of psychiatric providers, whether that be physicians or nurse practitioners, where if they're licensed in the state, which they are, of course, and working for our organization, we can share resources across and offer a virtual presence. Right. So let's say I have a provider at a facility in St. Paul, but there's a high need client or patient in Minneapolis. We have waivers to provide telehealth services across the licensed facilities. But that is still within the context of a robust support system physically present on the site, right? Psychotropic medications only work to a certain extent, and there's a large body of research showing that, whenever you have severe mental illness, there may be times where the psychopharmacological properties are rendered ineffective by the body.
That's concerning. And so you really can't be completely remote then. You do have to have that physical. So and so then that breeds the question. How are you in your organization able to function and do well and succeed in terms of staffing? What are the solutions that you have found to that problem where others have seemingly, continued to struggle?
I think, and we talked about this before we started recording, in 2023, the National Council for Mental Health did a comprehensive study across the country looking at turnover rates across different disciplines and industries. And they found that mental health specifically has turnover rates between 30 and 40% annually, compared to around 19 to 20% in healthcare overall. So that is twice as high, because the demand, again, is outpacing the availability. The other consideration is salaries have not maintained with the demand, right? I always joke around with people saying that, well, you can't drive a Porsche and afford budget, right? And there needs to be
It's
uh,
true. Yeah.
right, there needs to be
Yeah.
a standardization and equalization, if that's even
Yeah.
a word, of revenue, and looking at, comparing and contrasting what the facilities are billing, what they're getting reimbursed versus what the value of the services provided is being. One of the ways that I did it at previous organizations is implement performance metrics, so RVUs, or relative value units, to ensure that providers are meeting targets, but not using it in a punitive way, using it as a measure to see where they are and how to assist and help them in ensuring that they meet the targets. And if they're unable to, helping them remove barriers rather than shifting the blame on them, right? A clinician can only do so much. They're not necessarily able, given all the other competing needs and demands like documentation, to recruit their own clients as well. And so that's what we've kind of done here, is really try to create an environment that is responsive, but also invest a lot in training and ensuring that the facilities have the operational capacity and infrastructure to handle the clients that they're serving, which is why our staffing ratios are so high. There's not any single person responsible for delivering the care at any single moment in time.
Because I think when we had talked last time, I was actually quite surprised at the staffing ratios. What were they when we had spoken? I think it was
Here we have actually 22 staff and 10 clients. So it's
wow.
two staff for every client. And that's licensed professionals, unlicensed professionals, cooks, chefs, um, physicians, mental health professionals. The treatment director is a licensed mental health professional. The program director is a doctoral trained clinician. And so there's a lot of distribution of responsibilities and expertise. And so the facility that I'm sitting in now is the first of its kind where it's in IRTS, and there's many others in the state, but that's going to treat co-occurring disorders with the neurocognitive impairment component.
Wow.
So, and that was inspired by facilities historically admitting individuals for medically monitored withdrawal management or detox. And they may have some cognitive impairments that the provider deems as a result of intoxication, but once they complete the protocol, it becomes clear that it's an organic disorder due to Korsakoff syndrome or wet brain. Well, to that, you're not really returning them to a baseline that would be mine or yours, right? You are rehabilitating them to some level of functioning. Independence, unlikely. But then what would happen? They wouldn't meet the level of care at a hospital because it's too high, and they wouldn't be safe enough in a residential setting because they could get lost.
And I think that's important because what some of the things that we're seeing is that these facilities that some of the larger financial institutions are trying to start are there essentially are these like skilled nursing facilities or
Mm-hmm.
these facilities where the ratios are much larger and the care is not as intensive. But here's the question: how are you is your organization profitable, and how is it able to actually make revenue and be sustainable? Because what we're seeing is even organizations with tough staffing, with worse staffing, that have simpler, less complex patients, they're going out of business and going away, and the money's being invested elsewhere. But when we spoke, you said that the organization was doing tremendously well. And so I guess
Mm-hmm.
I'm wondering is how is that possible?
I think it's important to remember that any facility such as this one takes a while to be cash flow positive. The last one took us 6 to 8 months, right?
Mm.
So you have to have an upfront investment in the services that you're hoping to provide. But by investing a lot in staff training, and I'm not using that as a buzzword, right? We are meeting the statutory criteria for training, but then going above and beyond it. To give you an example, we are required by state law to train everyone in enhanced illness management and recovery through the University of Minnesota. So we have to do that, period. But then we have an internal protocol for integrated dual disorders treatment that we train everyone in. We also train everyone in nonviolent conflict intervention with a trauma informed component. We provide ongoing weekly clinical consultation across all of our sites where providers can come together and answer questions and support each other. And then we continuously use data driven practices to evaluate the clinical needs and the trends that are emerging across the sites in order to tailor interventions and training specifically to curb incidents. And so it's a very iterative process of risk mitigation.
Well, I wonder how during those 6 to 8 months, though, are you doing all of this risk mitigation and training as well, even when you're not cash flow positive?
Yeah. So, at least for intensive residential treatment services in Minnesota, it's a multi-step process, right? You have to get the permits, the zoning, then you have to get a supervised living facility license from the Department of Health, then the Department of Human Services license. Then you have to go through Department of Human Services for rate setting, which takes some time. You have to demonstrate, all the things that I've talked about. And once that is finalized, you are not billing for the interim period, but once it's approved, you're back billing.
Okay, so how much are we talking here? Is ending up being? Are we in the millions? Are we in the hundred thousands? I mean, is it a substantial amount?
It's in the hundreds of thousands.
Wow. So this could be and how many? This is a smaller facility compared to what some of the
Yeah,
right.
so these facilities, intensive residential treatment services, can be licensed up to 16. Can't go above that because it's intensive. A lot are smaller. The rate is publicly available information since it is, most of the funding is through the Centers of Medicaid and Medicare. I would say over 90% of our clients in intensive residential treatment services are through that mechanism. And so, to give you an example, one of the sites is charging per diem something around 750,
Mhm.
and then $50 for room and board. So it can be pretty substantial, but there is an upfront investment when you think about it.
a substantial upfront investment for that.
And I would argue to say that although it's not, formal in any sense or capacity, also serves as a deterrent for individuals seeking to go into this business for the sole reason of making money. Now, of course, you want to be able to have revenue and then reinvest and continue expanding, but that can't be the sole reason.
Right. There has to be, a kind of care for the community involved there because they need that intense level of care.
Exactly, and especially for these types of facilities, another factor in opening or requirement is a letter of support from the county in which the facility is going to be located, because you're serving that population. So every county that we're in or have been in, we do a demographic analysis of clients, patients, demographic factors, age, gender, sex, overall prevalence rates of various disorders, and then design programming to meet the needs of that specific community, and then have ongoing discussions and conversations with the county. So that all feeds into a strategic approach to making a facility long term sustainable and financially viable. Right, the alternative is you open a facility if your sole motivation is revenue generation without looking at the underlying factors, and then a year down the road you're surprised why there's no need.
I think that makes me ask the question though is that it is still profitable and does still generate revenue even with those challenges and with that long-term sustainability kind of as the approach. I feel like we shouldn't be in as much of a crisis as we're in now. Right. I
No.
feel like there shouldn't be people with, in a manic episode or in, a schizophrenic episode and my wife has bipolar. I interact with individuals a lot. And so I know that my sister-in-law, for example, had to be in one of the similar facilities for a little bit. So I understand what it's like to be in those situations. And I don't
Mhm.
understand exactly why we're not able to provide care for people who are actually they need it. They're seeking it out, and they're
Mhm.
being told to there's no room or to wait or essentially things like that. So why is that happening still, despite profitability, despite the possibility, other than staffing?
Mhm. I mean, several different factors, as I mentioned previously, but when we talk about it, it sounds easy, but the actual execution of the operational strategy is exhausting, right? To give you an example, when we license one of these facilities, we have to submit a policy and procedure manual to the Department of Human Services that meets various statutory criteria, right? Like the Program Abuse Prevention Plan. The length of those manuals is around 350 pages. And you're doing that for every facility. Now, there are individuals out there who copy and paste, right? Policy manuals, but the Department of Human Services is a relatively small within that division, so you can see similarities. But if you're designing programming and services that are uniquely tailored to the population you're serving, which is a best practice, it takes a lot of time, and that's just the policy documentation. Beyond that, you have the trainings, and I'll tell you what I currently mentioned or previously mentioned. You also need 30 hours of training on various requirements before you can even set foot into the facility.
Oh wow. Okay. It's that investment of time and well, really time, right? And mental effort.
I think that it does serve as a good deterrent because unfortunately, every field is prone to fraud, waste, and abuse. I don't think that's unique to mental health. But if you are being asked to go through a complex process and are unable to do so, it leads me to wonder clinically whether you can handle then the needs of the individuals you will serve in the long term, right? Because I may sit at a computer and look at numbers, but those numbers are people. And whatever intervention or directive I may give at the executive level doesn't only impact the staff that is directed to execute those, but also the client, the patient, their family, and the members of the community. And if we get too far removed from that, we tend to lose focus and become disconnected. It's that age-old trope of senior leadership giving directives without fully understanding the cascading effects of what that means.
If you could give, and I really appreciate your time, and I'll just ask this one last question. If you could give kind of one or two tips for individuals who really love the mission and then who are looking to do something similar in their own kind of geographic areas, what are some of the tips that you would give leaders in this area?
The strongest predictor of a positive therapeutic outcome is the relationship. It's not the intervention, it's not the medication, it's the human connection, which oftentimes is the source of suffering, but then also the source of healing, hope, and inspiration. And in a world where everything is moving very quickly, and I'll be honest in that I thrive in a world that's somewhat chaotic and crisis oriented. There are people like that. It's important to slow down and listen, and not just doing it to check the box, right? Let's say I'm going through a document or I want to submit a form, and I'm frazzled or distraught or anxious. If I take a step back and think about it, it's a expectation that I'm imposing on myself. And if I can remove myself from that expectation, I can execute it more faithfully. And talking with other people, so many times we live in a society, in a world, especially so after the pandemic, right? We're still not sure and familiar of the social determinants of health that resulted following a long period of isolation, that we've grown accustomed to not picking up the phone, calling, asking, networking, if you will.
Yeah, I found in my business and almost every job that I've had, it does come down to that as well. The people, whether it's colleagues, our customers, internal, external, it is the kind of the most vital aspect of kind of success, I think. And then it's also interesting, that flows down in mental and behavioral health, even at the clinical level. So, really great advice. Thank you so much for coming on, Damir. I really do appreciate it. I hope we can have you on again as well.
Absolutely. Thank you for the opportunity, Cole.